Thank you very much, Dr. Minal Khanna. Ladies and gentlemen, it's really my pleasure and privilege to address you in this Gopi Devi oration. I have been asked to address the question, how has rivaroxaban changed cardiology practice? And listening to the former session, learning about the interventions being employed, I think what we have in low-dose rivaroxaban is vascular protection delivered via an antithrombotic approach. And this treatment will become the standard of care for long-term secondary prevention across a broad spectrum of vascular patients, thereby changing cardiology practice around the world. My disclosures are here. I want to start by reminding ourselves of where we've come from over the years. And the first anticoagulants that we had, particularly unfractionated heparin and warfarin, were detected by serendipity and used for many years. And I heard the speakers at the earlier session tell us that they still used low-dose warfarin. I fear more out of desperation than out of evidence, because low-dose warfarin has not been shown to provide vascular protection. We went from the serendipity phase into the designer parenteral drug phase. And today, we have available a series of designer oral drugs, of which rivaroxaban distinguishes itself by the extensive nature of the development program. In atrial fibrillation plus, I don't have time to address all of the indications, VTE prevention, VTE treatment, and the focus of my talk, low-dose rivaroxaban plus low-dose aspirin for vascular protection in cardiology. I will address two issues. Firstly, I will review with you very briefly the overwhelming evidence from randomized trials that using low-dose aspirin in combination with low-dose rivaroxaban in vascular patients prevents vascular events and saves lives. I will then turn to address this challenging issue. Well, where do we apply this treatment? How do we get the biggest benefit for the buck, so to speak? Who is at highest risk and who should be treated with this therapy? Well, let's start with the randomized trials. And in truth, even to discuss these trials, time does not allow, because we have trials, the Atlas trial in coronary disease, the Voyager trial in peripheral artery disease, and the Compass trial, chronic treatment, long-term treatment in coronary or peripheral artery disease, more than 50,000 patients in randomized trials. In the Compass trial alone, we've published over 50 papers detailing the benefits of the Compass regimen across a very broad spectrum of vascular patients. In parallel with this, we also have large registries, so an overwhelming body of evidence. I'm going to focus primarily on the chronic management of coronary or peripheral artery disease. The design of the Compass trial is interesting because it was a 3-arm study in which low-dose aspirin was the control and 2 different strategies involving rivaroxaban were tested. We expected to continue for 3 to 4 years in this trial, but halfway through the trial, the DSMB indicated that we must discontinue because of overwhelming evidence of superior efficacy of rivaroxaban and aspirin. Indeed, the benefits were deemed to be so large that there was an ethical imperative to stop randomized evaluation to make this treatment available as soon as possible for patients with coronary or peripheral artery disease. The main outcomes are shown here. And when you look at the relative risk reduction, a 24% relative risk reduction, it seems rather modest when seen on a bar graph. But I'll remind you that the relative risk reduction of adding rivaroxaban to aspirin is of the same magnitude as a statin or blood pressure lowering. These are very substantial benefits, particularly when applied across a large number of patients. There were consistent reductions in cardiovascular death, in stroke, and in myocardial infarction. One of the most striking results was a very large reduction in stroke. As cardiologists and vascular specialists, I do not fault you for focusing your attention on coronary risk. But we have to remember that for every 3 myocardial infarctions in this coronary or peripheral artery disease population, there are 2 strokes. And our patients fear strokes at least as much as they fear myocardial infarction. And if they can avoid a stroke, a 49% reduction in ischemic stroke, this is going to be an extremely attractive option for them. The reduction in ischemic stroke was not accompanied by an excess of hemorrhagic stroke, which was very reassuring. We reduced stroke by a large amount. We also reduced major adverse limb events by a large amount. And this is a fascinating story. It deserves a separate discussion, but I will hit the highlights. Small number of people experience these events, but if you add low-dose rivaroxaban to aspirin, you reduce the risk of major adverse limb events or need for amputation by 1/2. That's the second big result from COMPASS. And the third, as I've mentioned, this treatment saves lives. And we saw this central line here is the estimate of effect on mortality. The upper line is the upper 95% confidence interval. The lower line is the lower 95% confidence interval. We saw a mortality benefit emerge very early and persist throughout the study. The only thing that changes is that the confidence intervals become narrower as we get more data. So a trifecta of less stroke, less amputation, and saving lives. I've put this one slide in here to remind the interventional cardiologists who may be viewing this presentation that the treatment effects of low-dose rivaroxaban in combination with aspirin are not only of at least similar magnitude as dual antiplatelet therapy, but unlike antiplatelet therapy, it saves lives. A 1/4 reduction in mortality in people randomized anywhere between 1 and 10 years post-PCI. So even if your only mission in life is to revascularize coronaries, this result should impact your practice in high-risk long-term management. Now, there was a price to pay. As with all effective treatments, we pay the price in some way or another, whether that be financial, whether that be side effects, or here, whether that be bleeding. You will notice on the left-hand side of the slide, our primary outcome, which was a modification of the standard ISTH definition, one that was indeed more liberal, so we had higher event rates than the conventional definition. With aspirin alone, after 3 years, 3.5% of patients had a major bleed. With rivaroxaban plus aspirin, the new treatment, 4.5% of people had a major bleed. An absolute increase, which in actual fact is only about 1 and a little percent. So a very modest excess of bleeding. The bleeding in almost all patients was very readily manageable. Here is the bleeding with aspirin. 1/3 or 30 with rivaroxaban plus aspirin, 30% required a transfusion, 26% required it with aspirin. And if you look at the other types of treatments that were used, they were used the same in both groups. Because bleeding occurred mainly in the first year, the net benefit, that is the ischemic events prevented in the first year, already outweigh the bleeding. In the second year, they greatly outweigh the bleeding. In the third year, because we're not seeing more bleeding, the net benefit gets bigger and bigger and bigger. This is shown here also. For CV death, the curves continue to diverge. For stroke, the curves continue to diverge. For MI, the curves continue to diverge. For symptomatic bleeding into a critical organ, there is an increase in the first year, but then the curves are parallel. There is no further excess, and there is no increase in fatal or intracranial bleeding. If we put this into perspective with other long-term antithrombotics, rivaroxaban added to aspirin is the first therapy since aspirin alone to significantly reduce mortality. This is why rivaroxaban plus aspirin has become one of the prime treatments for long-term secondary prevention in chronic coronary or peripheral artery disease. In all other cases, there was perhaps a favorable trend for mortality, but in no case does antiplatelet therapy alone, other than aspirin, reduce mortality when used long-term. I want to spend the last few minutes to address the issue of applying these results in clinical practice. We have an overwhelming body of evidence. We're sitting in our clinic, and we need to decide who to treat with this new therapy. Do I treat everyone? Do I treat a select few with certain clinical characteristics? Where do I start? What do I do? Well, up front, I want to say that as clinicians, we're always trying to tailor the therapy for those who get the biggest benefit of the treatment. And for this, compass is very clear. I think the key considerations are as follows. The compass regimen with low-dose rivaroxaban and aspirin demonstrated a clear net benefit of treatment. The net benefit got bigger over time. The relative benefits were consistent in people in low, medium, and high-risk groups. I'll show you that data in a moment. And therefore, the absolute benefits are greatest in those at highest baseline risk. A very simple formula. We know the benefits are biggest in those at highest baseline risk. Therefore, they are the ones we should target. Who is at highest baseline risk? And I'm going to suggest to you there are three possible approaches. Many experienced clinicians can tell instinctively. They can tell by their sense, their clinical sense, who is at high risk. And you don't need a scoring system to know that someone with diabetes, who's young, who's got complications of coronary disease and peripheral artery disease, is a super high risk. They should be included and treated with this regimen. So one is to use gestalt or clinical judgment. The second is to remember certain clinical characteristics. For example, if you have polyvascular disease, disease involving more than one vascular bed, you're very high risk and an ideal candidate for this therapy. If you have coronary or peripheral artery disease and mild or moderate heart failure, chronic kidney disease, or diabetes, you are at high risk and derive the greatest benefits from this regimen. There is perhaps the most compelling evidence of what I've just said comes from this paper, which we published earlier this year, where we looked at the mortality benefit of low-dose rivaroxaban in people who had one of these high-risk features, two of these high-risk features, or three or four of these high-risk features, compared with those who had no high-risk features. Now, when we split the data like this, the individual parts are not statistically significant, but we look at the consistency of the treatment effect, and the p-value for interaction is not significant. Therefore, statistically, these are the same. Therefore, the greatest benefit is in those at highest risk. We prevent 53.9 lives for every 1,000 patients treated for 30 months. That is an extraordinary benefit of a long-term antithrombotic. So this highlights the patient clinically at highest risk benefits. Here are the data looking at polyvascular versus single vascular bed, heart failure versus no heart failure. And in the gray column is the absolute benefit at 30 months. In the orange is the absolute benefit at 24 months. And blue is the absolute benefit at 12 months. So across the board, there is benefit. It accrues over time. It's greatest in the highest risk categories by vascular disease, heart failure, chronic kidney disease, and diabetes. There is a third way to detect or to identify the patients at highest risk. You could simply count the number of cardiovascular risk factors at baseline. You could simply count the number of medications at baseline, or even calculate a CHADS-2 score. We use it for atrial fibrillation, but the higher the score, the higher the baseline risk. Here you count risk factors. The more risk factors, the greater the benefit. Here you count how many pills the patient is when they walk into your office. The more pills they're on for cardiovascular disease, the greater the absolute benefit of treatment. Here you do a CHADS-2 score. You simply count your atrial fibrillation risk factors. In people without atrial fibrillation, the higher the score, the greater the benefit of this treatment. I'm going to end by saying not everyone should be treated. There are certain people who should not be treated. Clearly, if you already need full dose anticoagulation, you should not be treating these people. Clearly, if you have an unacceptable risk of bleeding, note that I'm not saying high risk, because people at high ischemic risk are at high bleeding risk. And we have to change our thinking, and we need to identify people with unacceptable risk of bleeding and not treat those and treat the rest. I'll show you what I mean by that in a moment. We should not treat people with contraindications. And clearly some people can't access the drug or be followed. Now, what do I mean by unacceptable risk? Here is an example from atrial fibrillation. As stroke risk goes up, bleeding risk also goes up. But the stroke risk goes up more steeply than bleeding, and therefore the absolute benefits of anticoagulation in AF is in people at highest risk of bleeding. But we should not treat the unacceptable risk of bleeding. For example, prior history of life-threatening bleeding when the underlying cause has not been identified or remains untreated. People who have recurrent major bleeding where the underlying cause has not been identified or remains untreated. People with spontaneous subdural hematoma. People with a lobar intracranial hemorrhage due to amyloid angiopathy. And another example, people with moderately severe thrombocytopenia. This is the type of patients who we should not treat. And then, of course, people with contraindications. If your GFR is less than 15, we're doing a trial at the moment, but it hasn't yet been completed in those people. People who have liver disease at baseline with an elevated INR, people with certain drug-drug interactions, and people who are allergic. Mr. Chairman, gentlemen, ladies, in summary, I've given you a short overview of the role of rivaroxaban at low dose for vascular protection. This is going to be your new tool of the 2020s for vascular protection across the range of patients with coronary or peripheral artery disease. Rivaroxaban is the first oral anticoagulant that's now been shown to save lives when added to antiplatelet therapy in both acute and chronic coronary artery disease. The highest risk patient derives the greatest benefit. And I leave you with a challenge, because leaving the pills in the pharmacy or on the shelf is not going to prevent MACE and save lives. We need to start treating our patient. And I'm aware that in India and in many other places, this treatment is now generic. So it's become more affordable than ever. I thank you very much for your attention.
Thank you very much. That was indeed a very, very good presentation and very informative one. This is a part of the oration. This is one of the most prestigious oration of our society. It is one of the orations which we gave last year to Dr. Farid Murad and earlier to Dr. Alan Tribier. And this is on, it's a Gopi Devi oration, which I will just read out the citation. Gopi Devi oration for the year 2021 has been conferred to Professor John W. Eikelboom from Canada, Faculty of Health Sciences, McMaster University, for the topic of COMPASS trial, how rivaroxaban has changed cardiology practice. At the 13th Asia Pacific Vascular Interventional Course held virtually at New Delhi, India from 19th to 21st December 2021 for his distinguished contribution to the field. Asia Pacific Vascular Society wishes him many more years of good health and academic excellence, dated this 21st day of December 2021. And I will request Professor Mrinal Kanti Das, who is the ex-president and mentor of Cardiological Society of India, to actually present it to you virtually, and we will make sure that we will send it to you personally through the post or through a courier. Dr. Das, please.
Yeah, it's a great pleasure to hand over the citation, and it was a fantastic oration. At least myself has been benefited because of the fact that if new facet he has analyzed and he has described, that is the higher risk of patients are more benefited with the low dose rivaroxaban along with the aspirin, and that's a very important key message that should be received by everyone who is listening today. And with that note, I congratulate Dr. Eikelboom for his erudite deliberation on rivaroxaban, and please accept our this oration award. Thank you very much.
Thank you very much. I'm very much honored to receive this award from you. Thank you very much.
Thank you.
Thank you very much, Dr. Eikelboom and Dr. M.K. Das.